know from a lot of research done now, not only in the US but also in other countries, that mental health problems, mental health disorders are the single most robust predictor of attempting suicide, completing suicide. 65 to 90% of people who will go on to complete suicide will have a diagnosable mental health disorder for at least a year. And that, of course, means that 10% or more will not have a diagnosable disorder, at least around the time of death. So maybe they had something diagnosed earlier, maybe they have just the wrong mix of environmental stressors and genetic predisposition and brain vulnerabilities and coping style that puts them at risk and disconnectedness. And again, that mixture together can be at just the wrong time to lead someone to try to take their own life. It's very hard at this point to know, is there one particular risk factor? But we do know, for example, that kids who are bullied, kids who may be at risk for substance abuse, kids who are trying to figure out their sexual orientation, they fall into it's a sort of added level of risk that might get placed onto them, in addition to if they have, for example, the previous mental health disorder history, or someone in their family struggling with a mood disorder, or someone in their family having committed suicide or trying in the past. And so it's important as clinicians for us to understand what are the stress factors in a child or teen's life that may put them at risk. And also importantly, what are the protective factors or resiliency factors? What are the assets? What are the positive connections that we need to take advantage of as clinicians and as a community? For example, is there someone in the school that they are connected with? Is there one caring adult or two caring adults that they could name? Could be a teacher, could be an advisor, could be a coach, could be a staff at the school. But for many of our kids who are attending public school, in elementary and middle school, they're 30, 35 hours a week, they're with a consistent set of adults. It's important for us as clinicians and parents to really be able to tap into that and to have someone at school who we feel really knows our child. And that's become important for us in the community in Palo Alto as we think more deeply about these connections, because there are a lot of caring teachers and staff in the community who want to help. And part of the work we do there is trying to help teachers by giving them some tools for being able to reach out to teens, and also to give teens the tools to be able to help one another out in terms of getting peer help or getting help for themselves. What we like to teach about in our training program is really to take all talk of self-harm very seriously. And if a teenager is talking about, if they start to have very dark themes in the therapy that are new, if they really start to talk a lot about sad mood, and then there are a whole list of other signs that would be worrisome in terms of changes in behavior, loss of interest in things, giving possessions away, starting to talk about death and dying. And what we're understanding now with social networking is there are often some signs that on Facebook or on some of these other sites that a kid or a teen may be in distress. And we don't really have enough data to say, well, if they say this, therefore it means that we need to get them in to see someone or get them into an emergency room. But we are understanding that social media is very powerful, and it's a very important tool that we as clinicians need to try and understand better, because that is the number one way that many teens are communicating with one another currently. So we really do need to understand social networking